Welcome to Nitte, a place where learning goes way beyond the classroom. For some, it's home. For some, it's a step towards transformation. For some, it's the beginning of a wonderful journey with like-minded people.
Thanks to the teaching and mentoring activities and dynamic incubation center, I am now industry ready.
Engineering at Nitte includes aeronautical, civil, computer science, electrical and electronics, electronics and communication, information science, mechanical, biotechnology, MTech, MCA and PhD. Nitte also collaborates with reputed universities around the world to give students an international academic exposure.
At Nitte, the focus on research has not only helped me understand my subjects, but reach for the stars.
Nitte offers a unique co-op program and exposure to architects, artisans and urban designers.
I aspire to be the heart of progress.
Chema is listed in the World Directory of Medical Schools.
I learned the art of helping people smile.
A.B. Shetty Dental College is listed as one of the top dental colleges in the country. Justice K.S. Hegde Charitable Hospital, part of the Nitte Group, has 1,000 beds, advanced labs and diagnostic centers, which attract a good number of patients from across South India. Along with teaching and clinical practices, we offer programs in pharmacy, nursing, physiotherapy, speech and hearing, biomedical sciences, and paramedical programs like respiratory therapy technology, operation theatre technology, medical imaging technology, and medical laboratory technology.
I've always been curious about the chemistry of cures. I help in healing. From toddlers to seniors, I care for them all.
I believe I can help improve the quality of other people's lives.
We are blessed with the ability to speak and hear from birth. Not everyone is as lucky. I want to do my bit to help the less fortunate. I am proud to be able to assist a surgeon in the operation theatre.
From simple X-rays to sophisticated MRI and PET scans,
my course trains me to assist radiologists and physicians. The training I have received in testing blood, tissues and body fluids assures me a job at any clinical laboratory. I I help people enjoy every breath.
I believe in the power of research to change the world.
NUINS is a one-of-its-kind teaching and research center that addresses society's health needs through painstaking research in biomedical sciences, food safety, microbiology, and biotechnology.
What I learn here and at my internship in the University of Minnesota, USA, I will carry with me and teach my community to live healthy and stay happy. We believe in being our own bosses.
The Bloomberg Lab helps students stay up to date with the latest trends in global markets. Students also have access to Bloomberg Analytics and can, in the course of their learning, develop their own analytics.
I cook my own recipe for success.
Sarosh Institute of Hotel Administration molds each student to become perfect hospitality professionals. A healthy blend of polish and panache.
I speak for the voiceless. This is what I'm taught, and this is what I'll practice.
I design my dreams and my goals.
I measure success by the trends I inspire.
Bachelors in Fashion Technology at Nitte offer students state-of-the-art labs and the space to get their creative juices flowing. With the best of infrastructure, an active placement cell, and a lively atmosphere, education at Nitte helps students grow, breathe, and bloom. Graduate into a better future. Graduate with Nitte. Welcome to Nitte, a place where learning goes way beyond the classroom. For some, it's home. For some, it's a step towards transformation. For some, it's the beginning of a wonderful journey with like-minded people.
Thanks to the teaching and mentoring activities and dynamic incubation center, I am now industry ready.
Engineering at Nitte includes aeronautical, civil, computer science, electrical and electronics, electronics and communication, information science, mechanical, biotechnology, MTech, MCA, and PhD. Nitte also collaborates with reputed universities around the world to give students an international academic exposure.
At Nitte, the focus on research has not only helped me understand my subjects, but reach for the stars.
Nitte offers a unique co-op program, an exposure to architects, artisans, and urban designers.
I aspire to be the heart of progress.
CHEMA is listed in the World Directory of Medical Schools.
I learned the art of helping people smile.
A.B. Shetty Dental College is listed as one of the top dental colleges in the country. Justice K.S. Hegde Charitable Hospital, part of the Nitte Group, has 1,000 beds, advanced labs and diagnostic centers, which attract a good number of patients from across South India. Along with teaching and clinical practices, we offer programs in pharmacy, nursing, physiotherapy, speech and hearing, biomedical sciences, and paramedical programs like respiratory therapy technology, operation theatre technology, medical imaging technology, and medical laboratory technology.
I've always been curious about the chemistry of cures. I help in healing. From toddlers to seniors, I care for them all.
I believe I can help improve the quality of other people's lives.
We are blessed with the ability to speak and hear from birth. Not everyone is as lucky. I want to do my bit to help the less fortunate. I am proud to be able to assist a surgeon in the operation theatre.
From simple X-rays to sophisticated MRI and PET scans,
my course trains me to assist radiologists and physicians. The training I have received in testing blood, tissues, and body fluids assures me a job at any clinical laboratory. I help people enjoy every breath.
I believe in the power of research to change the world.
NUINS is a one-of-its-kind teaching and research center that addresses society's health needs through painstaking research in biomedical sciences, food safety, microbiology, and biotechnology.
What I learn here and at my internship in the University of Minnesota, USA, I will carry with me and teach my community to live healthy and stay happy. We believe in being our own boss.
A very good morning and a cordial welcome to the Day 2 webinar Experientia, Acquire, Adapt and Share, an international alumni webinar series. I, Priya Montero, Joshni and Reshma, can you mute your mics? A very good morning and a cordial welcome to the Day 2 webinar Experientia, Acquire, Adapt and Share, an international alumni webinar series. I, Priya Montero, Joint Secretary of Alumni Association, NUINS, will be moderating today's session on hemodialysis. The quality of care that patients receive is fundamentally related to the knowledge and skills of the RN. Nephrology nursing is a specialty practice addressing the protection, promotion, and optimization of the health and well-being of the individuals with kidney disease. These goals are achieved through the prevention and treatment of illness or injury and elevation of suffering through patient, family, as well as the community advocacy. So here we are to acquire, adapt, and share the expertise of our alumni working national and international health sectors. Welcome is a universal gesture. At the outset, I extend my warm welcome to Mrs. Joshni D'Souza, Associate Nurse Unit Manager, Epworth Healthcare, Australia, and a proud alumni of NUINS. She had done postgraduate certificate in renal and acute care nursing. She had also completed renal dialysis training at Austin Dialysis Training Center at Orbos Dialysis Unit. We welcome you, Mrs. Joshni. The second speaker for today's session is Mrs. Reshma Mascarenhas. She is a RN. She is working as a dialysis nurse in 7 years. She is in Justice Case, Hegde Hospital, Delicate, Mangalore. She had done her PG diploma in dialysis nursing from Nitte University. We welcome you, Mrs. Reshma Mascarenhas. It's an immense pleasure to welcome Dr. Fatima De Silva, Principal College of Nursing and ex officio President Alumni Association of NUINS, to this webinar. We welcome you, ma'am. I also bid a cheerful welcome to all the organizing committee members, NUINS Alumni Association, and a special welcome to all the delegates who are logged in. Once again, I welcome you all. Now I request Mrs. Joshni to take over the session.
Thank you, Priya. Hello, everyone. I'm Joshni, as they introduced me. I work as a dialysis nurse as an associate manager. So today we will cover a few topics in brief. So mainly I will start talking about a few things which is important for us to know, like kidneys. So when we talk about dialysis, we know we are mainly concentrating today on kidneys, the functions of the kidneys, and just give me a sec. Sorry, Priya, I'm just not able to see my yeah, thank you. Okay, so today I will just cover a few topics like about kidneys in brief, renal failure, the treatment choices where we mainly want to discuss about dialysis today, the principles of dialysis, the Dialysate, the Dialyzers, the dialysis machines that we use in Australia, and patient evaluation. That's where we mainly focus on the nephrology nursing. And under that, we have main concepts of dialysis like the access that we use, the complications of dialysis, medication, and patient education. So I will be going in brief about the first few topics because we've all learned about kidneys. I think we consider kidneys not as important as the brain or the heart, but if the kidneys fail, we are in a lot of trouble. So the main functional unit of the kidney is a nephron. So we know each kidney has approximately 1 million nephrons, and nephron is the site of urine production. So when we say that, it occurs through filtration of blood in the glomerulus, the reabsorption of water and solutes in the loop. It also facilitates concentration of dilution of urine, and also the distal convoluted tubule also helps in the further reabsorption of the secretion and the secretion of the solutes. So this is mainly where, can I have the previous slide, please? Sorry. Yeah, so in this diagram, when you say nephron, it is a very small unit of the kidney, but when it comes together, it does all these functions. And if the kidneys fail, so all these toxins get built up in the body and you need them to be flushed out. Yeah. So what do the kidneys mainly do? So the kidneys mainly help in the fluid and electrolyte homeostasis, the removal of metabolic waste, regulates our blood pressures through the renin-angiotensin mechanism, secretes erythropoietin, which is very important for our red blood cell production, acid-base homeostasis, excretion of through the excretion of acid and production of bicarbs, and the calcium and phosphate metabolism. So, and this happens through the activation of vitamin D. So all these have a mechanism, how they take place, and we all have learned with our anatomy and physiology. So this is where this is why we have to take care of our kidneys. So when all this fails, what happens? So if there is a sudden, the kidneys cannot excrete the metabolic wastes, the patient builds up a lot of fluid, builds up a lot of nephrotoxins, and that's why it's called a renal failure. So with renal failure, there can be mainly two types. There can be acute renal failure and a chronic renal failure. With acute renal failure, there's a sudden or the rapid loss of kidney function, which may be which is reversible in most of the cases. So this comes with sepsis, cardiovascular disease, a chronic heart failure, a vascular surgery, and nephrotoxins build up in the body. Antibiotics, like, if they use the third category antibiotics to treat sepsis, most of the patients end up with acute renal failure, and the nephrotoxic medications, also the IV contrast, sometimes causes acute renal failure. We've had few cases in the last 1 year that have come through to us that have had acute renal failure, mainly due to antibiotics and sepsis. So in these cases, what happens is the patients are treated in a different approach. So first they treat the cause of the renal failure. So whether it is caused due to antibiotics, they try and reverse the cause. They try and restore the volume homeostasis. They put them on diuretics, see if they can flush the fluid by themselves, or they try and correct the electrolyte imbalances like the sodium, the potassium, the calcium, phosphates, and the bicarb levels. And also they have to try and correct the hematological abnormalities such as the hemoglobin, because if the kidneys fail, there's no red blood cell production in the body. So, and this can also be incorporated by putting a good diet into the patient, but they also use something called hemofiltration in the ICUs, where a different machine is used to provide a kidney function on a temporary basis. So they kind of filter the patients for 24 to 48 hours and help them reverse the kidney function. But if they do not regain their kidney function within a week's time, that's when they send them for intermittent dialysis. And we have seen these two patients who were on intermittent dialysis for a couple of months because they were treated with strong antibiotics, nephrotoxicity built up, and their kidneys failed. So when so what we do is we monitor their kidney function. So we do pre-bloods and post-bloods. So that gives us a clearance of their kidney function to tell us how much better they get. So this is monitored very closely in acute units. I'm not sure if there is a concept of acute and a satellite units in India. So we have separate acute units and satellite units. And the unit that I work is a hospital unit. So we do function as an acute unit, but we are basic healthcare providers for a public hospital provider, and we're contracted to them. So we don't do many acute patients. We do mainly chronic patients, but we do come through 1 or 2 patients through the year. So chronic kidney failure, this is where mainly hemodialysis or intermittent dialysis comes in act. So chronic kidney disease is nothing but a progressive, irreversible decreased kidney function for 3 months or more. So in Australia, we have a very different way of approaching any chronic disease. So we have something called a chronic disease a management team. So it is monitored very closely. So we all have a Medicare, so for which we are covered on healthcare. We do not have to pay for it. So we have a regular check. So as soon as you go on an age basis of 40, 50, your blood pressure gets monitored, your diabetes, if you've got a family history. So all these gets monitored. So when it comes to a chronic kidney disease, they start monitoring your kidney function. So they randomly ask you to do your renal function test, your liver function test. So all these gets checked annually with age and other factors. Or if you suddenly come to a hospital with something, it gets monitored and it gets picked up. So when it comes to chronic kidney disease, it's an progressive, irreversible decreased kidney function. So in this case, it decreases in stages. So in the first stage, the eGFR is less than it's more than 90, where there's no kidney damage or nothing that you can see. So it's normal. You might have a little bit, which is still categorized as normal. Stage 2, which will show you a little bit of a decreased glomerular filtration rate. And this is usually in patients who have hypertension, diabetes, or other major illness. So what they do is they try and control these 3 causes, like they try and manage diabetes very well, they try and manage the hypertension very well. So if these are managed well, they do not get pushed into more decreased renal function. So moderate function, when their eGFR sits between 30 to 59, they're closely monitored. They are often referred to something called a renal services team. So every area has public hospital, they have their own renal teams, and with this renal team they have an entire team, like a nurse practitioner, there's a dietitian, there's a renal a transplant team, there's nephrologist. So before going to the nephrologist, they do have to go through many other steps. So they start with the general practitioner, then they go through the nurse practitioner. So they kind of first manage the causes of the chronic renal failure. And the main causes of renal failure chronic renal failure in Australia are diabetic nephropathy, glomerulonephritis, hypertension, polycystic kidney disease, and reflux nephropathy. Especially in case of polycystic kidney disease, they are monitored right from the beginning, from childhood. So if they've had a family history, they are monitored because they are more likely to end up in dialysis because they can't function with a polycystic kidney disease. And hypertension, because we all know the renin-angiotensin mechanism, how it works. So if you end up with severe hypertension, your kidneys are definitely affected, and the diabetes as well. So when it goes to severe decreased rate of the eGFR, the patients are educated to tell them that, look, if you decline further, you will end up having dialysis or you'll need a transplant. So all these are very closely monitored here, and the end stage disease is nothing but where they end up in dialysis or require a transplant. So when they end up in the last stage or closing to the last stage, the patients are informed of the types of dialysis that we provide in Australia. So we have got something called peritoneal dialysis, which is not commonly seen as a practice. They still do it according to the convenience of the patient and depending on the renal function of the patient. Then there is hemodialysis that we do commonly here. Home hemodialysis is nothing but dialysis, but the patient is trained to dialyze by himself or herself at home. So the whole setup is done at home because it's much cheaper to have it in a satellite compared to home, in home compared to a satellite unit, because you have to pay for the resources in the hospital. And nocturnal hemodialysis is done in certain units. We haven't started yet. We have a project to start nocturnal hemodialysis in the hospital, which means you're going to dialyze patients overnight. So they will dialyze for 6 to 8 hours, which is very gentle and helps with their clearances in a better way. With their cardiac function improves with doing gentler dialysis, because the satellite dialysis that we do is over 4 to 5 hours, depending on the patient's condition. which is a bit more aggressive than compared to nocturnal and home dialysis. And renal transplantation is a vast subject. So patients in Australia are offered a renal transplant if they are eligible for it. So if their health condition is better with their cardiac functioning. So there are certain health conditions that do not let you be on the list, but we have a national list that renal transplant workup is a major process. It takes up to a year for a patient to be worked up for a transplant. So they go on a national match. Donor. So if, for example, if I had renal failure and my husband wanted to donate me a kidney, and if it matched with everything, with all the cross match, the blood group and all the antigen antibodies, then I can directly have, but still they have to still go through all the workups. Whereas if it's a deceased donor, what happens is the sample gets matched on the national list, depending whether it's interstate or it doesn't matter. So the organ gets transported to that particular state to whom it matches, and it gets. And in Australia, I think the latest they've done is a 7-way transplant, where if I had a person who wanted to donate me a kidney but did not match with me, but matched with another third person who had a partner or a sibling who wants to donate a kidney, but even theirs did not match. But if it went crossways, like if that kidney matched me, or they do a 3-way to 4-way or a 5-way transplant. But the latest that I heard was a 7-way transplant that took place 3 years ago with 3 different states, which was a great achievement for the team, a renal team across Australia. So a little about peritoneal dialysis. So peritoneal dialysis works a different way. So here, so it uses the peritoneum, the lining of the abdomen, to filter blood inside the body. And there are 2 types. They do a continuous ambulatory dialysis, and they do an automated peritoneal dialysis. So continuous, the patient has to manually do the exchanges, which takes 30 minutes. So they use a bag of fluid hung on an IV pole, and they have to do this frequently because otherwise their metabolic waste doesn't get excreted, and they have to do it 3 to 4 times a day, the exchanges, otherwise they will retain fluid. Whereas the automated peritoneal dialysis, this requires a machine, which is like a cycling machine, which they can use overnight. So the patients do it overnight at home. They can go to sleep, and the machine just helps automatic filling and draining of the fluid through the lining of the abdomen. So that's that picture which says, where the peritoneal, the dialysis solution sits in the peritoneal cavity. Through the bag, it goes into a Tinkoff catheter, and then it drains down into another bag. I personally haven't worked with patients who do peritoneal dialysis. I've only studied theoretically because we do not offer those services in our hospital. There's only a public hospital in Geelong that offers peritoneal dialysis. So coming to hemodialysis. So what is hemodialysis? It's nothing but doing the function of kidneys artificially. So it's way of cleansing the blood of the toxins, extra salt and fluids through a dialysis machine using a dialyzer and dialysate fluid. So here, because the kidney cannot function, you totally have to use something else to do it. So the blood comes out of the body, goes into a machine, goes into something called a dialyzer, and using principles like ultrafiltration, diffusion, and osmosis, the blood gets filtered. So here the substances move across a semi-permeable membrane in a dialyzer to remove the unwanted solutes and fluids to restore the acid-base balance via an extracorporeal circuit. It is called an extracorporeal circuit because it's happening outside the body through a machine. And in this particular dialyzer, the pores of the semi-permeable membrane allows the fluid and electrolytes to pass, but not larger substances such as blood cells. So with the blood molecules, they do not pass through these membrane. Only the other molecules such as the potassium, the urea, the creat, the sodium, so excess molecules of the unwanted products are moved through these principles. So let's go to the principles of dialysis. I'll just give a brief. So we've got ultrafiltration here in dialysis. So what happens is the fluid moves across a semi-permeable membrane, and this will move from an area of a higher pressure to an area of a lower pressure, and this is influenced by a pressure gradient in the dialyzer. So it just helps the fluid to move from the area of where there is more higher pressure to an area of lower pressure. Whereas in osmosis, they use osmosis where there is movement of water from an area of lower concentration, lower solute concentration to an area of higher solute concentration. Or alternatively, the other way around, from an area of high water concentration to an area of low water concentration. And diffusion is nothing but the movement of the solutes from the regions of high solute concentration to regions of low solute concentration. With the diffusion, so these are the dissolved particles across the semi-permeable membrane from area of high solute to low solute. So here, the semi-permeable membrane is the synthetic membrane, like it's an artificial collagen located in the dialyzer. So smaller molecules pass freely through this membrane, like the urea, creat, and the potassium, whereas the larger molecules of the blood remain as it is. This occurs because of the concentration of these solutes is higher in the blood than it is in the dialysate. The concentration gradient is maintained throughout the entire length of the dialyzer by employing a countercurrent system in which the blood flows through the dialyzer in one direction and the dialysate in the opposite direction. When I have a further slide, I will show you, because the dialyzer has two arms. So the blood goes in one direction through the red arm, and the dialysate moves into another. So here we have something called the dialysate or the concentrate, which is used in dialysis. So this fluid is made up of two components. It's got the acid, which comes in the bottle, which is the transparent bag, and there's the little bag, which is called the bicarbonate bag, which contains the bicarbonate. So when the kidney function fails, the bicarbonate levels drop. So we need something to keep it, to buffer it, whereas the acid levels have increased. So when the acid and the bicarbonate are mixed with the RO water, they become the dialysate. So when I say RO water, so most of the they use something called a reverse osmosis, where the water is filtered and it comes to the machines. So that's called the RO water. So the chemical composition of that bag is nothing but the bicarbonate, whereas when it comes to the bigger bag that we use, the fluid, there is sodium, there's potassium, there's chloride, there's calcium, magnesium, glucose, and bicarbonate. And when we say it just can't be in any amount in this bag, it has to have a certain level. So every bags come with a number. So we use a machine called Fresenius. So those bags come with different numbers. So they say a smart bag of 31125. When you say smart bag of 31125, which means 3 is equivalent to 3 millimoles of potassium, 1 is equivalent to 5 millimoles of glucose, and 1.25 is equivalent to 1.25 millimoles of calcium. And there is small amount of magnesium, small amount of chloride. So all these together come in one bag so that it can go through the machine and balance the electrolyte imbalances in the blood of the patient. And this is nothing but otherwise called the artificial kidney, a dialyzer. Currently, we use the high flux dialyzers. We don't use the hollow plate. So these high flux dialyzers have this semi-permeable membrane which can allow the movement of ones that need to be excreted. They have got a higher capillary density. So that's where it gets attached to the machine, and one of the arm gets attached to the red one where the blood gets in, and the other one where the fluid gets out. So these are the Fresenius machines that we use in our unit. I can't explain a lot to you over a presentation about the machines because it's all technical when it comes to dialysis. You have to manually learn every single part of the machine. Especially these machines are very advanced. I think in India they use the 4008. So these are 5008, 5008S, which we have started using since 2016. So they have a digital screen. They tell you if you've done something wrong. So the screen actually prompts everything to you, how to line the machine, tell you if the machine's not lined the right way, and it does its own test. It has its own pressure test and everything. So when you go to a unit, first what you do is set up the machine with just the lines. So all the lines are use and throw, so use it once. So the lines, the machine has 2 pumps, the ones that we use. So this particular machine shows 3 pumps, but it's for a single needle dialysis, which is not commonly used. It's only when you fail the access. Whereas these 2 pumps there on this particular machine, the bottom ones where you can see the blood on. So the red one is the arterial pump, which takes blood out of the body. And the one below that, the pump, is called the online HDF pump. So it's the fluid pump. So the fluid is regulated in the machine first. So we do not use saline bags. We only connect the pumps, and the machine itself primes the lines. I think the other machines that we used before these that I worked on in my previous workplace, they did not have the self-priming machines. So we had to use normal saline to prime the lines and make sure there was no air in the lines, because technically that air would go into the patient, which is very dangerous. So these machines are very good. They are very advanced. If there is air in the lines, it will just keep alarming. It will not let you go through with the treatment at all. And the machine has a spot to put a anticoagulant. So we put heparin, or the patient gets a Clexane directly through the lines. So it's very important to keep the anticoagulant running in the machine once the patient has started, so that the blood doesn't clot through the lines, because there's 300 mils of blood outside the machine every minute. Outside the patient's, outside the patient in the extracorporeal circuit. So we have to make sure there's enough heparin or enough Clexane given to the patient at the start of the run. So the dialyzer is at the side, and it's practically not possible to tell you what this machine can do, but it does what dialysis does, but it also does more functions called blood volume monitoring. So we can actually see on the screen what percentage of fluid the patient is carrying. Like there's something called a critical related blood volume. So if it starts with a percentage, so if it drops below 80%, then we know we have touched the body weight of the patient. And it also does a blood volume monitor, where it tells us the hemoglobin of the patient. It's got a little digital monitor there, tells the hematocrit of the patient. It helps us to tell if the patient is dry, because it gives the initial hemoglobin and the post hemoglobin as well. So that's basically the Fresenius machines that we use. So that's just another picture of that machine. Actually, the picture on the right is exactly the basic 5008 machines without the third pump. And that particular machine does not have the blood volume monitor. Only the one on the left has the blood volume monitor. So coming to the important part. So when we have been referred patients for dialysis, we have an approach to the patients. So most importantly here, patients are evaluated based on their weight and their fluid state. Like, how do you get a fluid status? So when they go to an appointment to see their nephrologist, so once they are assessed very well in an acute setting where the nephrologist have to check their jugular venous pressure. If it's elevated, they will tell by how much and how much fluid they're carrying. But they will set up as an ideal body weight, which is called a base weight for a patient. So this weight is very important for us because we have to weigh pre and post when the patient comes in for dialysis. So the pre-weight when they come in is compared with the base weight. So the base weight is nothing but there is no clinical evidence of edema. So when the patient nephrologist assess them, they should not have any swelling, any shortness of breath, or increased jugular venous pressure, or hypo or hypertension. So it takes a while for the nephrologist or the nursing team to come to a conclusion with the base weight. And when with renal failure, you can see if the patient has accumulated a lot of fluid, you see a lot of swelling in their feet, swelling in their ankles. The edema is definitely a pitting edema. They're short of breath. So all these factors we have to keep in mind when the patient comes in. So when he comes in, we write down the weight. He or she comes in, we write down the weight. And then we have a base weight. Like if the patient comes in at 81 kilos and the base weight is set at 79, which means the patient has put on 2 liters of fluid in the last 2 days, because definitely they cannot put on body weight unless they're constipated or they've had a different scenario. So then what we do is we take that 2 liters as the weight to be taken off, and we add another 800 mils in our unit, which we allow for food and fluid. Because our machines have give 300 mils to the patient, which is primed, that is calculated as a washback, and that is added to that. So we take 2.8 liters off over 4 to 5 hours. And when I say base weight, this can be changed up to a kilo or half a kilo or a kilo by the nursing staff. Mostly the senior nurse or the nurse in charge can do that with the consultation with the doctor. If they've had any signs and symptoms of hypertension through the run, or if they've had, if they think they felt crap leaving, dialysis the previous run, because most of our patients, when they come in, we say, how do you feel? How you felt last run when you went home? And they will say, if they felt good, they will say, yes, I felt good, I had a good sleep. But if they said, oh, it was bad, I cramped, I couldn't sleep through the night, I felt like my blood pressure was low, I felt dizzy. So then we know we have done a bit too much on the patient. We have taken off fluid that we shouldn't have taken off. So we can rectify that one by putting up the weight by 0.5. And because it's all computer systems, and doctors can be contacted immediately through a message, or we just write notes, say that, look, the patient complained so and so we had to put up the weight by 0.5 kilo for today, and we will see how we go, and they can be assessed in the next clinic meeting. And most of the patients get reviewed every 3 months by the nephrologist, but we have a system where we do 6 weekly bloods on our patients. So this is done as a protocol. So every hospitals have their own guidelines and their protocols. So we follow strictly our region protocol, where we do bloods every 6 weeks. So we do pre-bloods and post-bloods. So this gives a good clinical picture of our patients. So this is reviewed by one nephrologist who is on duty. So this is reviewed by the nephrologist on call, and this gives a clinical picture of where the patient stands with their toxins, with their fluid status, and how they're clearing with dialysis, and with their general health. Jyoti, I've just missed the presentation slides.
Is it visible now?
No, sorry. No, it's not that. It's not this one. Ah, yes. Thank you. So you can ask me more questions at the end about patient evaluation, because approach to patients here is very different, I believe, compared to how they do it in India, because here it is more of a comprehensive approach. We've got a massive team and there's so many people that look after them. So coming to the next topic, vascular access for hemodialysis. So when I say we have to dialyze the patients, we need an access. So when a patient is diagnosed with end-stage renal disease and needs dialysis, most of the patients are prepared. So when they are in their third stage, so if they are prepared in the third stage, they are picked up and prepared, and the prognosis is on right track, they will have arteriovenous fistula created prior. So this is a preferred access for choice of dialysis because it is less prone for infections. It is less likely than a graft to have any clotting problems. So they can also have a graft, which is artificial, whereas most of our nephrologists prefer the own arteriovenous fistula, which is created using their own artery and a vein. And they also provide a good blood flow and they last for decades. And it is very good for clearances. Whereas in acute renal failure, so what happens is the patients come in with acute failure. So they get a central venous access device. So that is a temporary one. So what they do is, because acute's temporary as well and it is reversible, they put a central line and they use the arterial line and the venous line. So arterial line is used to draw the blood from the patient and venous line is used to return blood from the patient. So in case of arteriovenous fistula, so they take a cephalic vein of the patient and a radial artery and perform anastomosis. So in that picture, you can see where the cephalic vein is thickened and dilated because that's where the blood has to be pumped back to the patient. And whereas, so pumped back and drawn back. So you can feel the vessel very prominently when it is, so any AVF created can't be used straight away. So even with chronic renal failure, even if the AVF is created, it may not mature in time. Usually takes 6 weeks. The surgeons prefer to give it 6 weeks before we touch it. And the patients are given exercises to be done for the vessel to mature. It depends where the vessel is. Some patients mature very well, sometimes they don't. So we can do ultrasound. So we've got ultrasound machines in the unit where we kind of look at the vessel, see how much they've been dilated, what the diameter of the vessel is. So it gives you a clear picture with the ultrasound, how long the vessel's grown, how can we access it? Because we literally have to put 2 needles in 3 centimeters apart on that particular vessel. So the vessel will be pretty small when created, but it does grow to be bigger and thicker in time. And some patients, most of the brachiocephalic ones mature quicker and they tend to get bigger as well, whereas the radiocephalic kind of stay very superficial and nice for the patients because they don't like their vessels to be dilated a lot. For the appearance purposes, but we can't help with it. So if it gets a lot higher, bigger, and the blood flow through the vessel is kind of maintained to, we try and achieve above 500 to a liter. they do not prefer anything about 1,500. If there is a blood flow of 1,500 per minute, they try and ligate the vessel and make a new one. Or sometimes they even kind of balloon it and see what the problem is with the vessel. So these are the common sites here. That's the radiocephalic fistula with the radial artery. So most of the patients have the vessels right on their arm here, which is a bit tricky sometimes because they sit on the bone of the arm. Patients prefer it on the brachiocephalic here because then they can cover it with their clothes as well. Here, the brachial artery is connected to the cephalic vein, and brachiobasilic is very, very rare. I think most of our patients have the radiocephalic and the brachiocephalic fistulas. And surprisingly, we have none who have one in the femoral vein. So coming to the central venous access device, which is also called as the permacath here. This is done on urgent basis, like for acute renal failures, whereas with chronic renal failure, these particular ones can last for a year. But I have to tell you, we've had a patient who had it for 10 years because technically not allowed to, but that was the only access for her life. If something went wrong with that, she had no other access left in her whole body for dialysing, and that would be the end of her life. So we had to leave that catheter in, which was very good. So it all depends how you look after a central venous access device, because it has to be sterile when you access it. So here, if you can see the catheter, I don't know if the picture is very clear enough. The tip sits in the right atrium of the heart. And you've got two lines. So one is the one with the red and the blue. So it's just like the needles, where the red one needle is the arterial needle and one needle is the venous needle. There you access the fistula. Here you've already got those two lumens. So what you can see in the little one, the yellow device is something called the TIGO, is a pressure bung. I'm sure you must have seen something in the ICUs on the peripheral lines where they put a pressure bung. So some units in Australia use these pressure bungs, which are only for they're only for the central lines. They're called the TIGOs. So they can be accessed without having to do a proper sterile dressing. So for dialysis, what we do, because the patients come 3 times a week, we just wipe them with the chlorhexidine swabs for 30 seconds, let them dry, and then access them. So they don't need to be taken off every time. So those pressure bunks let you access right from outside. As far as you maintain sterile techniques or aseptic techniques, when you access them without taking them off, we are safe. But we have to be very careful, because we've had cases where patients have ended up with sepsis if not accessed properly. This is just like a picture to tell how our patients, I did want to put a photo of one of our units, but I had to take permission. So that's the chair. So most of our patients who come to satellite units have a recliner. They are much better than those, what looks in the picture. They are very comfy. The chairs go flat if required. In emergency purposes, they can go flat for a CPR. They recline very well. They are very soft, so the patients can sit for 5 hours. So they sit just beside the machine. So the machine doesn't face the patient. The machine sits besides the patient, and their lines go either way where their fistula is, and the machine's basically got the lines. We don't use the normal cell line. It's got the Dialysate bag, the tubes, and the connection to the patient. Coming to the complications of hemodialysis. So the more common complications when you start hemodialysis in a patient is they drop their blood pressure. because you're trying to take fluid off the patients, you have to be very gentle. So what happens is, because you're artificially trying to pull something off, the heart doesn't really manage well. So for the initial runs, we try not to take any fluid off. We start with, when a patient goes on to dialysis, we start with for 1 hour first, to be gentle, to see what we can do, taking no fluid off, just dialyzing. Then second run, we do 2 hours and see what the blood pressure does. So we have to monitor the blood pressure as soon as the patient comes into the unit. So there's a sitting blood pressure done. We see how they go within half an hour. With patients starting first, we have to monitor every 15 minutes. Mainly because of hypotension. And if there is hypotension, it is very significant in patients, because they won't tell you if they felt it. They would just go flat on you. They will, they kind of collapse, so you don't see any signs and symptoms. So if you're not monitoring it, you wouldn't even know until you might even lose the patient with hypotension. So you have to be very careful, monitor them. But there are few patients with hypotension can tell you if they have cramps. So they start cramping in their legs or arms, or tummy cramps. So then you know, okay, there's something going on. And then you check their blood pressure. Their blood pressure is pretty low, and then you can manage. So hypotension. So when you say hypotension, there are certain patients who can have a normal blood pressure of 100. And for some patients, 100 systolic is very low with dialysis. And there are patients that we ignore blood pressures of 90 systolic because that's normal for them. And there are patients we can still take fluid off with the systolic blood pressure of 80. And the blood pressure keeps improving as the dialysis goes forward. And with muscle cramps, they are very severe. Patients suffer a lot when they have a cramp. It's not a normal cramp. It's very different, where they cannot move. It's something, we can't imagine because we don't get it. So the only way we manage hypotension and muscle cramps the same way: we stop taking fluid off, we give them a bolus, we lie their head flat, we put their feet up. With cramps, we tend to provide heat packs or ice packs, whatever helps the patients. They try to put their feet against a resistance, and sometimes that helps. So these are the two common ones. And there are some patients, very rarely you see they have nausea and vomiting, especially if they've had a big meal. During dialysis, vomiting is the first sign that you see when their blood pressure drops, because if they try and eat a meal when they're on the machine, the blood circulation goes for the digestion process, and they kind of lose their blood pressure peripherally, circulation peripherally, and end up with hypotension. Headaches, chest pain, hemolysis, air embolism, which is very rare because the machines are so advanced, they won't let even a little bit of air go through the venous chamber. So there's something called a venous chamber and air trap. If air goes through that, it's detected, or even if there's a clot through that, it is detected. Hemolysis, the water gets tested for chlorine every morning in units in Australia. So there's shouldn't be any hemolysing seen commonly as well, because if there's increased chlorine in the water, that's one reason where you see hemolysis. Arrhythmias and cardiac arrest, that commonly happens with the poor cardiac function of the patient. If they have a pacemaker, or if they've had stents done before, they've had cardiac problems, that's where you see those both. So with the medications in dialysis, we mainly use anticoagulants in the machine. So that's the first thing that goes in the machine when you start, because the blood has to circulate for 4 to 5 hours. And if we do not calculate the right amount of anticoagulant for the patient, we can lose that 300 mils of blood, which is a lot. So we start titrating with heparin. So whenever a patient starts on hemodialysis, we start heparin because heparin is reversible. So whereas clexane is used a bit later. I think I'm running short of time. I better make this quick as well. So this heparin helps the line, keep the line clear. Erythropoiesis stimulating agents, which are also called the ESAs here, or the EPOs, they are given because of the decline in kidney function and their inability to produce the red blood cells. And these help or boost the red blood cell production. Iron, because of the red blood cells, there's less iron, iron stores are dropped in renal patients. Phosphate binders are given for patients because most of the patients tend to eat high phosphate food and that's not excreted. So, and because there's calcium deficient, there's no way phosphate can be excreted. So our calcium bound to the calcium phosphate. So they need phosphate binders to get rid of that out of their body. Antihypertensives in hypertension, vitamins, and the proton pump inhibitors in most of our hypertensive patients as well, and laxatives because hemodialysis causes constipation in some patients. So coming to patient education, it's basic because we need to educate them on fluid restriction because they cannot just drink whatever they want. They are on a fluid restriction of 1 to 1.2 liters a day. If they go above that, they have to have extra runs or they go on a strict fluid restriction monitoring. We do dietitian referrals. Most of the time it doesn't really help, but we try our best reminding them and they don't like it. Diet, again, the same thing, phosphates, potassium, calcium. So all this is emphasized with diet. And the compliance of medication, we have to check with all our patients. We do a primary nursing care model. So we check with all our primary patients whether they're compliant with their medication because it does reflect in the 6 weekly bloods. Care of the AVF. So when a patient has an AVF, we make sure we tell them every time, we remind them every second week. Initially, they're given all the education, but we tell them they have to feel for the thrill and bruit in the fistula. There's a very strong thrill and the bruit. If that goes missing, they're in deep trouble. We've had few cases where they don't feel it, and when they come to the hospital, the fistula is clotted. So no restricted clothing, no blood pressure on that particular arm, no cannulation and no venipuncture. So if the patient is educated, even if the patient ends up in a different hospital, they know how to tell them not to do any of these things on that fistula arm. They are even advised not to lift any heavy objects, even if they went to the gym, to avoid lifting heavy objects with that arm. And if they have a central venous access device, they have to avoid swimming to prevent infection, and also to report signs of infection and redness and pain. So we'll keep the questions for later.
Thank you, Joshi.
Yeah, thank you. Sorry, I just took a bit more time. I'll come back to that.
No problem. From Dr. Fatima De Silva, we have a question. How do you calculate the base weight?
So the base weight is calculated, so it doesn't come in initially. So because they've got a lot of fluid on board with renal failure, because they've got so much fluid in the tissues around their heart, their lungs. So this is being assessed in an acute setting by the nephrologist. The nephrologist monitors them every day, assesses their jugular venous pressure, and if it is elevated by more than 3, so then they say fluid needs to come off. So when you come to a certain point that they show symptoms of hypotension, visibly you see no fluid, but they end up with hypotension, they end up with cramps. That's where they set their body weight at. So because then you know it is their body weight and not a fluid weight. So there should be no edema, no shortness of breath. The jugular venous pressure should not be elevated. So they all can come to that point in that first 2 weeks of the acute setting when they are in an acute unit.
The second question from the student. Can patient take a visit to dialysis center before they start with the dialysis?
Yes, most of our patients do. So what happens is, because they've got this good team around them, they get a tour of the hospital. They get a tour of the whole team. They get introduced to their nurses, to their nurse practitioners, to their nephrologists, to the machines, and they show them what exactly happens in a dialysis unit, so that they're not in a shock.
What are the pre-blood workup done before dialysis?
So pre-blood for transplant or dialysis?
Before dialysis.
We don't do pre-blood workup, like you're saying, before commencing dialysis or every run?
Yes, before commencing dialysis.
Before commencing dialysis, their renal function tests are monitored. So depending on what the cause is, diabetes, hypertension, so all the renal function tests are monitored. Their electrolytes, calcium, potassium, sodium, and all the other electrolytes, the iron levels, the hemoglobin is monitored, because they tend to drop their hemoglobin very quickly.
How do you manage hypotension, Joshni, when patients come with hypotension during the dialysis?
So during dialysis, if they have hypotension, so initial management is done by the dialysis nurse. So we stop taking fluid off. That's the first step. And then we immediately press, there's an emergency button on our machines, which really helps, because it does a blood pressure immediately, blood pressure check. It gives a bolus. So we give a bolus of 150 mils. We lie the patient flat, put their feet up. So when their feet are elevated, it usually helps. So after doing all these steps with the bolus, with the feet elevated, but lying them flat, and giving them a bolus of 150 to 300 mils and not taking any fluid off, with all these measures, within 2 to 3 minutes, if the patient hasn't recovered from hypotension, then we call a med call. We call the emergency code. But usually most of the dialysis patients recover with the bolus of 150 to 300 mils, and their blood pressure recovers. So they recover, like they respond to the bolus, but the blood pressure recovers in 10 minutes.
So do you have a protocol of keeping certain parameters?
Yes. So
Like
every patient has their own, so every hospital have their own guidelines, and every patient have their own parameters set up. So if the patients with polycystic kidney disease, some of them cannot maintain a good blood pressure above 100 normally. So the minute the blood pressure drops to 70 systolic, we have to stop taking fluid off.
Since dialysis is an expensive procedure, how is dialysis paid for in Australia?
So because we have something called Medicare, we all pay taxes. So the government has provided Medicare nationally. So that covers the cost of all the treatments in Australia. So per patient, we spend $75,000 a year in a satellite unit for dialysis. But the patient pays nothing, zero. All the treatment, dialysis 3 times a week, 4 to 5 hours. They get dietitian services, physio services, food, the nephrologist visits, and everything is covered. Everything, and food as well.
what's the dose of heparin?
Sorry, Fatima ma'am.
What is the dose of heparin given to patients?
So we start minimal, depending on the weight of the patient. So if the patient is of 100 kilos, we start with a bolus of 2 and hourly 1, which is standard, but 2,000 units bolus and hourly 1,000 units bolus. So what we do is, after every dialysis, we have to check the dialyzer, how clear the membranes are. So if the membrane's clotty, then we have to increase the hourly bolus. Otherwise, if it's very clear, then we start titrating, we go the other way. But we do Clexane in our units, because most of the patients have acute setup in their main hospital, and then they come to us. So we start with the base. So 60 kilo patients, we do 40 milligrams of Clexane. 80 kilo patient, we start with 60 milligrams of Clexane, but that is decided by the nephrologist, but titrated by the nurses in consultation with the doctors.
Okay. What is your independent role as a dialysis nurse? What activities do you take up?
As a dialysis nurse, like in general, as a dialysis nurse, we do evaluate patients. We do, follow up for patients' bloods. So patients come with various complaints. So we have to assess their fluid status, assess their complaints, why, if they complain of dizziness post-dialysis, we have to see. So what we do is we monitor it for a week, we see why it has happened. So every clinical picture of a patient is assessed by the dialysis nurse because they're only seen by the nephrologist once in 3 months. I have a lot of protocols in the unit because I act as a nurse unit manager. I review all the bloods for the patients. So we've got 43 patients on board now. So I do all the clinical review of all my patients' bloods, and I go for a meeting with one of the nephrologists every 6 weeks to decide what their prescription should be. So depending on the bloods, their hemodialysis prescription changes to what fluid we can use on the machine, how much fluid we have to take off, or what medications needs to be changed. So we do that. And there's a lot of other roles like providing, patient referrals for dietitian, referrals for occupational therapy, physiotherapy. They need social work support because hemodialysis really puts patient in a different position. They need a lot of support here.
Do you have any specific dietary restrictions given for these patients?
Yes, when they start dialysis, they have to see a dietitian. So they have to restrict high potassium diet, high phosphate diet. They are encouraged to have high protein diet after the acute period, and so that the albumin doesn't drop. Mainly, we ask them to be very careful with the high potassium diet because any potassium above 6 is dangerous to their health. And the phosphates, when it goes above 1.5, they go on phosphate binders and fluid restrictions, of course. We try and tell them, because some people say, oh, we didn't have fluids, but I had yogurt, but yogurt is technically fluid, or I had custard. So for telling a common person about that, diet restriction or fluid restriction is not an easy job. So we try our best. We keep reminding them, but they have to see a dietitian every 6 weeks.
What is the advice given with regard to the fluid restrictions?
It depends what the patient's got on its clinical picture. If they've got pitting edema to start with, they've got fluid around their lungs, fluid in the, if they've got any bilateral effusions and cardiomegaly and all that, then they start with 700 mils. We are very strict with their fluid restriction. But the problem is, if they are as an acute inpatient, then we can monitor it. But once they go out of the unit, we do not monitor it. So they are responsible for their own fluid restrictions. But most of our patients are on a fluid restriction of 1 liter to 1.2 liters, and they are pretty good with maintaining it. So 1 to 1.2 is common.
Joshi, thank you so much, and it was a wonderful presentation. I think what's the time over there?
It's 5:40 p.m.
That's in the evening or in the morning?
In the evening, 5:40.
In the evening, yeah. Thank you so much. It was really a very excellent presentation.
Thank you, ma'am. Thank you so much. Thank you.
Thank you, Joshni.
Yeah.
Here we'll start with the second session.
Yeah.
Mrs. Reshma Mascarenas, can you continue with this session?
Hello, I'm Reshma, registered nurse working as senior nurse at dialysis unit, Justice KCP Hospital. Ms. Joshni already she has explained regarding the kidney injury and chronic kidney disease, the principles and indication of dialysis. So I'm now taking topic regarding the hemodialysis in India. Hemodialysis, it is estimated that about 2 lakhs new patients develop end-stage kidney failure every year in India. So dialysis is it is a treatment choice for CKD. And secondly, it is transplant, which is not, it is common, but more important is given for hemodialysis. So the dialysis indication and patient evaluation, everything is similar what Joshni has explained in her presentation. Access, we'll come to the access. We in India, in my department, we have we initiate dialysis through temporary and permanent access. Temporary is femoral catheter, jugular, internal jugular catheterization, then perm cath, also called tunnel catheterization. These are the temporary. Tunnel catheterization or perm cath we use for a patient, those who are both AKI as well as CKD. AKI patient who might require more than 3 months of dialysis, and chronic kidney disease whose access is they don't have much vein, so creating AV fistula or the graft is not possible. And also patient choice, we have one patient who is scared of cannulation, so the boy is not willing for AV fistula. So according his based on his choice, we have kept a perm cath for as a temporary permanent access, you can call it as, because he has not created any AV fistula or the graft. We're still convincing him to make one AV fistula, so that we can heal in future. There may not be any kind of catheter related infection, and we'll come to the complications in dialysis patient. As Joshni explained already, we have a common complication as hypotension and muscle cramps. These are the commonest complication during dialysis. For hypotension, we immediate stop fluid removal, and we rush 100 to 300 ml of normal saline, and we elevate their foot end. Then for cramps also we decrease we decrease fluid removal. Then if muscle cramps subside, then we'll continue the dialysis. In some patients that is they can't tolerate, they have severe cramps, which is not normal cramps which normal person they get, which is severe, and they cannot tolerate. In that case, we inform nephrologist, and as they advise, if they advise terminate dialysis, immediate we terminate. Then we'll adjust their fluid target weight. We call it as here what Joshni has told, base weight. We call it as target weight, or we set their if the person or the patient is free from edema and his blood pressure is normal, there is no shortness of breath. In that case, we increase the target weight by 0.5. And in case if there is edema present, still patient had muscle cramps or the hypotension, so we'll increase the frequency of dialysis. And for example, if a patient who is undergoing twice a week dialysis, we'll ask him to do extra dialysis, that is every alternate days, so that we can reduce the incidence of getting muscle cramps again and again. Then other complication, that is like vomiting, nausea or vomiting. Then these are the commonest complications. Then air embolism, that it is very rare, but now we have a advanced machine which will detect air accidentally. Suppose and there is crack or while connecting the connector, there is any kind of loose, or in that case, the machine which gives an alarm, air detector, or by accidentally we have to our blood extracorporeal circuit, we have saline line, where accidentally opening of the saline line and entering of this is the main entrance where air gets entered. In that case, we stop the dialysis. We put the circulation in recirculation. Will make sure that all the air is removed and the circuit is full of free from the air bubbles. Then we reconnect it to a patient cannula or the side catheter side, and then we restart the dialysis. Then okay, these are the complication and management what we do in our dialysis unit. And the medication we use heparin, that is the anticoagulant. We use in my department we use only heparin as anticoagulant. And then iron sucrose, that iron is essential for the patient, as they have most of the patients are anemic, and in CKD, kidney is not able to secrete erythropoietin, so we got to give them iron as well as EPO to maintain the anemic status, hemoglobin level normal. And iron sucrose is dosage, it is maintenance doses once in 15 days, that is 100 mg iron sucrose and 100 ml NS at the prior to before the half an hour of the dialysis session. We administered iron sucrose, and erythropoietin is given post dialysis. Erythropoietin is given post dialysis. Then these are the medication we use during dialysis and for a dialysis patient. Then regarding patient education, like education is given on fluid restriction. Most of the patients they follow, and many of the patients they are oliguric. And during this, we our coastal city, it is we cannot. Our patient is they, if how much ever we educate them, but it is at this in this coastal city, it is very difficult during the summer season, that they get thirst, and they say it is very difficult to have put restriction on that food intake. So in that case, they increase the dialysis frequency, like from once in a week to thrice, or the alternate day they get dialysis. Then diet is low potassium, then low sodium diet, and we educate patients regarding compliance of with the medication. Then care of the temporary as well as permanent access. And temporary access, we educate our patient to not to soak their dressings, and care should be taken while having bath. Then in permanent access, we advise them to not to lift heavy objects, and not to put pressure on their fistula arm or the graft arm. Then and our dialysis team, in my department, we have nephrologist, a dialysis doctor, then hemodialysis nurses, and hemodialysis technician. In India, we have hemodialysis technicians, but as hemodialysis technicians who does the equal work where hemodialysis nurse does. Then a transplant coordinator and a dietitian, then a social worker. These are the this is a hemodialysis team, and we have a machine that is in our department. We don't have advanced Prosinus 5008S machine. Instead, we have hemodialysis 4008S machine. We have a satellite unit where only the CKD patient they get dialyzed, stable CKD patient. They get dialyzed in satellite unit, whereas in hospital dialysis unit, we dialyze acute cases in intensive care unit as well as in the department and chronic. But whereas in satellite unit, where only CKD patients, stable CKD patients, they get dialyzed. And here, I think I'll be concluding my talk regarding the dialysis session in India and about the cost. Here, dialysis is not free of cost. We have to, each person get to pay. Only few they get benefit from government. That is those who are eligible. Eligibility is a person who should hold a below poverty card, that is BPL card holders. They are eligible for free dialysis. And other than that, each patient in India, they get charged approximately 1,500 to 2,500. And regarding the dialyzer, we reuse dialyzers that is up to 10 to 15 users, and it is depend upon the total bundle volume. If it is below 80, we discard the dialyzers. Then and the blood tubings are single use. We don't reuse, we don't reprocess. So we after each use we will discard. Only the dialyzer we reuse here in our department. So I think I have almost completed my topic. So if you have any questions, please.
Reshma, you said that you reuse the dialyzers. How do you, is it for the same patient you use the dialyzer?
Yes, ma'am. It is for the one dialyzer is each first patient. We name their name and register number on the dialyzer. We reprocess it. We have a reprocessing machine. We will reprocess it through that machine, and we use peracetic acid as a disinfectant and cleaning agent. Every 48 hours, we reprocess that dialyzer. For example, in some patients, they have dialysis once in a week. So every 48 hours, we reprocess that dialyzer. We note down their total bundle volume, that dialyzer's bundle volume, and if we found dialyzer the total bundle volume is less than 80, we discard the dialyzer and replace with the newer one.
So when
what was that bundle volume you were referring to? How do you assess that?
We have a reprocessing machine, and that reprocessing machine will detect. It will display the bundle volume. If it is, it will also display whether it is failure. Everything that dialyzer gets into a blood leak test, then air detector test, then it will also detect the bundle volume. That in that machine we have a display. It will say that the bundle volume is less than 80. And it shows failure. So at that time, we will discard that dialyzer and replace it with newer one.
Reshma, I was just checking, what dialyzers do you use that you can reuse?
We use Frusinus with high flex dialyzer, polysulfone dialyzer we use, which is of F6 for almost, we use F6 dialyzer, which is 1.3 millimeter surface area.
Okay, so you are allowed to use these reuse, because we don't use any of the products. Again, it all goes
Yes.
into infectious bin. Is it because of the cost?
Yes, the dialyzer costs around 1,000, and most of the patients, they are not affordable. So
Yeah.
we use dialyzer. We use dialyzer. If patient is willing, with their choice, we have single-use dialyzer also. But those who can afford, for them, we use single-use dialyzers.
So when you say cost, do they have to pay for every treatment?
Yes, for each and everything they got to pay. It might be a dialysis charge. Then for the erythropoietin and any medication they get during dialysis, it might be blood components or erythropoietin. For each and everything, they got to pay.
Okay. Even the lines? What about the lines? Do you reuse them?
No, no. For the lines and dialyzer comes with dialysis charge, and
Okay.
even consultant charge.
Okay. So they have to pay for the consultant for every dialysis treatment?
Yes.
Okay. So that's a difference here. Our patients do not pay for the consultants. It does, like even with the public budgeting, it doesn't come out because they are reviewed by the consultant only once in 3 months.
Okay, but for
Like even if
here
it's a
we
private
use.
Reshma, do you go as a home dialysis nurse? Do you play any role for home dialysis?
No, ma'am. Here in India, it is not that much common. Home dialysis. Most of the 99% of dialysis patients, they prefer to come hospital and they get dialyzed.
Yeah.
What about you, Joshni?
So we don't, there is a lot of home dialysis, ma'am. So every patient that goes through the first public sector, when they go through the prognosis, like health assessments, they're checked if they are suitable for home dialysis. If the patient is young and the patient has the ability to learn, they do not tell them that there's something called a satellite unit. They tell them that they have to dialyze at home. So that's the first option because it is so much cheaper compared to having them in the satellite units. So they train them to needle. So they start training them how to needle, how to set up a machine. So they do home dialysis first. If they fail, then they come to a satellite. But there are some patients who will just refuse to even try it. Yeah, it depends. But there are even private patients who pay private health to have dialysis, like, patients who can afford. We are a private hospital, so we have private and public patients. So if the private patients want to set up home dialysis, they have to bear the expenses of plumbing their house.
Do you come across patients with hepatitis B because of dialysis?
Yes, we do have hepatitis. Hepatitis B positive, we haven't seen in the last 5 years. They're very good with vaccination. We check them annually. We have seen a couple of Hep C positive patients, but not in our unit, in other units. So they have to have the same machine and they have to be bleached once in a week. But because all our instruments that we use for dialysis is use and throw, we kind of follow the same precautions, standard contact precautions with patients. So it's not a big deal unless it's something rare like ESBL or VRE, where there's bug in the gut or bowel. We kind of take more precautions, contact precautions. Because it goes up.
Reshma, do you get a lot of cases of patients with hepatitis B?
No, ma'am. Even though we reuse dialyzer, but as in our unit, no one has turned to B or C positive. But in other hospitals, the patients, those who have got infected, they have dialyzing in our unit. So we have a positive hepatitis C machine, hepatitis C patient, where we have one machine only dedicated only for C patient, hepatitis C patient. And the vaccination status before initiating dialysis, they have to get vaccinated hepatitis B. That is 4 doses. It is 0, 1, 2, and 6 months.
And who decides that the amount of fluid to be removed? Is it the nephrologist or is it the nurse who is working in the dialysis unit?
For the initial page, our nephrologist they will tell us that this much fluid you need to be removed. They assess and they will prescribe a note, and that they will mention how much fluid to be removed, everything. Depending upon that, we set up a target weight. If a patient has reached his target weight without any kind of hypotension or hypertension or the absence of edema, we set it as the target weight.
Kindly excuse.
That was a very beautiful comparison which was given by Reshma by talking about how different is dialysis services in India compared to Australia. That was a beautiful presentation, Reshma. Thank you.
Thank you, ma'am.
There is a question from Janvi Chaira. I would like to clarify a doubt. My son was taken 9 cycles of dialysis at the age of 12 years, and now he is absolutely fine. What care he has to take in future? Joshni?
Priya, did you say he was dialyzed at the age of 9 years?
9 cycles of dialysis at the age of 12.
9 cycles of dialysis. So what was the cause of renal failure? Was it acute?
Nephrotic syndrome, ma'am.
So they have to monitor what they must have treated the cause of it. So if they have treated the cause of it, they have to monitor that it doesn't come back. So they have to make sure they check the renal function test at least every 6 months or every 12 months and make sure he doesn't come up with any other symptoms that can lead to renal failure.
Thank you, Joshni. Reshma, any output?
Yes, ma'am. That is similar. Like they have to in our setup, we advise them to do a renal function test every 3 months, so that because it is a pediatric case, we have to take care of them. Every monthly or once in 3 months, physician will advise them to do a blood test.
And I think even diet restriction would be the most important thing.
Yes, diet restriction.
Low sodium diet and
Thank you, Joshni, and thank you, Reshma.
You're welcome.
We don't have more questions. We'll end the session here. It was a very good session. Both of you done a very good explanation. Today, now I'm here to give vote of thanks. It's indeed a pleasure to give thanks to all those who have shared the responsibilities to make this event a reality. At the outset, I thank Almighty to gracing this occasion. A special thanks to Mrs. Joshni and Reshma for consenting to share that knowledge and experience. Thank you, Mrs. Joshni and Mrs. Reshma. I take this opportunity to thank Dr. Fatima De Silva, Principal College of Nursing, for her constant support and guidance. I'm grateful to all alumni members for their participation and support in planning and organizing the webinar series. My heartfelt gratitude to all the delegates for actively participating in the webinar. Thank you one and all. Have a great day. Delegates, please fill up the feedback form and post this form. It is very necessary to get the certificate. Thank you one and all.